Hello, everyone, and welcome to this session of the AI Nurses Network webinar series. We've a wonderful nurse with us, Hwayoung Cho, today from the University of Florida in the States. She's going to talk to us about machine learning in aging research. Over to you.
Hello, everyone. Thank you very much for this opportunity. It is a pleasure to share my work with the AI Nurses Network. And I am Hwayoung Cho, Assistant Professor in University of Florida College of Nursing in the United States. So today I will talk about how machine learning has been applied to cognitive health and dementia-related outcomes among people aging with HIV. And I will also connect this evidence to my current federally granted project, which is funded by the United States National Institute of Health, specifically the National Institute on Aging. This project focuses on dementia risk prediction and the development of an early warning system as a clinical decision support system for all the people with HIV. And I want to use this topic to discuss how nurses can interpret AI-related evidence and evaluate whether it is ready for clinical or research use, and also think about how AI can be responsibly translated into our clinical practice. So briefly introduce who I am and the areas that shape the talk. So my work sits at the intersection of nursing informatics, AI, and machine learning, and real-world data from electronic health records and social determinant of health and clinical decision support. And the focus today is I try to make it more practical. So what the current machine learning evidence tells us about cognitive health in aging people with HIV, and what gaps remain, and how those gaps inform my current dementia risk prediction project. So let me start. So the central message as that AI in nursing is not only about building prediction models. It's about using evidence responsibly in real clinical and research contexts. So AI and machine learning are increasingly used to detect patterns, estimate risk, and support decisions in complex populations. But actually the interpretation is not always straightforward. So just a high model performance score, we usually call this AUC, so the accuracy score, but it does not tell us the whole story. So for example, so the AUC, the score, tells us how well a model separates a higher risk from lower risk individuals. But it does not tell us whether the prediction model is fair, explainable, or it's actually validated or useful in our clinical care. So for actual clinical care, clinical care use, we need to think about data quality, external validation, and fairness, interpretability, and also our clinical workflow, and what action follows from the prediction to actual a clinical use. So prediction becomes meaningful when it supports earlier recognition and better conversation and more equitable and patient-centered care. So that was my a point for today. So this topic matters, especially my research area, because people with HIV are living longer now. So more than half of people with HIV in the United States are now aged 50 years old and older. So over 50 years old, and making cognitive health in kind of increasingly important issue in this HIV care. So all the people with HIV actually face a 60% higher risk of dementia compared to a general population. And cognitive concerns in these populations are layered because there are specific HIV-associated cognitive conditions. So, for example, HIV-associated neurocognitive disorder. We call this HAND, H-A-N-D, and HIV-associated dementia, and also just more likely generally Alzheimer's disease and Alzheimer's disease-related dementia. So this is clinically important for nurses because cognitive changes affect medication management, medication adherence, and safety, and their independence, also their caregiver needs, and also care coordination. So in this specific area, like early detection, because the dementia, we don't have like a cure for dementia treatment yet. So early detection and effective management requires evidence that reflects both the things like biology and the social context of aging with HIV. So, like machine learning can fit into cognitive health research because dementia risk is complex. So it is rarely explained by one variable. And it can involve a combination of diagnosis, medication, laboratory values, and EHR, the electronic health record notes, imaging, and also claims and social determinant of health, and probably patterns over time. So machine learning and natural language processing can help classify outcomes and estimate risk, also identify subgroups in this whole population, and extract information that may not be available in structured EHR field. But the value of machine learning is realized only when the model outputs are understandable and trusted by clinicians and linked to a care action. So prediction is not the same as clinical benefit. The clinical value comes when the output helps someone make a better decision or provide more timely support. Otherwise, probably the clinician or like providers do not accept this model or do not use this in their everyday care. So we conducted like a rapid system review to answer some of the questions in this area. So the focus question was, how has machine learning been applied to dementia-related outcomes in people with HIV? So we searched PubMed, CINO, and Embase in September 2024, and limited the research to the studies published within the past 10 years. So eligible studies were original research articles involving people with HIV, at least one dementia-related outcome, and at least one machine learning method used, and reported like model performance metrics. So the search identified 721 records. So after screening and full text review, 26 studies met the criteria. So we included these 26 studies in our final review of this rapid assessment review. And the number to remember is that this is an emerging area. So there's growing interest, but the evidence base is still relatively small. So actually, we did not have any evidence. So this slide summarizes what the 26 studies looked like. So most studies were conducted in the United States, followed by China, Canada, and a few other countries. And many use retrospective observational data, and several even did not clearly specify the study design. And the outcome focus was also important here. So most studies focus on neurocognitive impairment or HIV-associated neurocognitive disorder, as I mentioned, like a hand, and rather than just like all-cause dementia, like Alzheimer's disease or Alzheimer's disease-related dementia. So this creates a critical gap. So historically, in this area, so neuro-HIV research has focused on HAND, the HIV-associated neurocognitive disorder, only this one. But as people with HIV age, and they are living longer, we also need evidence on age-related dementia outcomes rather than just focus on HIV-associated cognitive conditions. And also, just like probably we need evidence on overlapping pathway involving HIV, aging, and comorbidities and social determinants of health all together. So in our systematic review, supervised machine learning was the dominant approach in this area, and using like 20 out of the total 26 studies. And 5 studies use a combination of supervised and unsupervised approaches, and only one used unsupervised learning alone. So deep learning here appeared in only 2 studies, and reinforcement learning was not yet reported. So these findings tell us that this field is still dominated by supervised prediction models applied to labeled outcomes. So these methods are, of course, useful, but they depend heavily on sample size, data quality, outcome definition, and validation strategy. So here the key point is that model type alone does not determine clinical usefulness. So like a simpler model with a strong validation, and also like something like a more clear, like a clinical interpretation can be more useful than just like a complex model that cannot be explained or applied. So here, the included studies also showed that machine learning can detect meaningful patterns in complex data in this research area. And several models reported promising classification performance for neurocognitive impairment or related outcomes. And also machine learning helped identify imaging and cognitive, like biomarker and clinical patterns that may be difficult to detect through manual review or traditional statistical method alone. So this is increasing, but the practical takeaway here is that clinical value depends on what happens after prediction. So the model that identifies risk actually needs to connect to screening, referral, monitoring, counseling, or other like intervention that the patient can use, or care coordination altogether. So I think like without that kind of next step, the model remains an academic just exercise rather than a clinical tool. So these slides highlighted the limitation that currently restrict like clinical use. So many studies had small sample sizes, which reduce like a model stability and reproducibility. And several cohorts were largely just like male and limiting generalizability to women and more diverse population. Also, cross-sectional designs were common, which make it difficult to model cognitive change like, over time. And the most important limitation is none of the 26 studies reported external validation across independent settings or population. And I think like that matters because a model can perform well in one data set and perform poorly elsewhere. So interpretability was also concerned. Here, like some machine learning patterns were predictive but difficult to explain biologically or clinically. So especially for nurses, the question is not only how accurate the model is, the question is whether it is safe or fair or explainable and actionable. So I know like I keep like emphasizing this point because I believe there are multiple prediction models, but actually just look, I'd like to discuss some like how we can make it like more meaningful. So here, this is a practical evaluation lens for nurses. So when reading an AA paper, I'd like recommend that just like do not stop at the model performance metrics. So like first probably ask like who was in the data, the ages, like sex and race and ethnicity and clinical settings, and also the disease stage all affect whether findings apply to your patient. And also probably we can ask what outcomes was predicted actually. So like a hand, like a dementia diagnosis or Alzheimer's disease or related dementia subtype or like a cognitive score and also disease progression are not the same outcome. So we can more likely specify the outcomes was predicted. Also, we can ask how the model was validated. So like external validation across the settings provide like stronger evidence than internal validation alone. So we can see whether there was the external validation or not. Also, we can ask whether clinician can understand the signal. So whether when we provide those like a prediction model, but if the clinicians provider cannot understand what this means, then it's really everything will affect our patient safety and outcome. So probably we can look for like a feature importance or rational and uncertainty and or some more like a plausible clinical explanation. And also I would like to emphasize one more thing, that we nurses can ask what actions follows. So prediction without like something clinical clear action, probably that can limit like our clinical value. So this semester review work directly connects to my federally funded project. So the review showed like a promising evidence, but also several important gaps I found. So like limited focus on all-cause dementia, including Alzheimer's disease and related dementia, and also there was like limited longitudinal and multimodal research, and also no externally validated clinical risk prediction tools. And also we found the underrepresentation of women and diverse population in existing machine learning studies. So based on these findings from the rapid systematic review, my NIA, the aging project responds to these gaps by using EHR, electronic health record, and real-world data linked with the social determinant of health from a large and diverse data network. And that project developed like a machine learning-based dementia risk prediction models among people with HIV aged 50 years and older, and prototypes an early warning system through user-centered design, and examines disparities in modifiable risk pathway. So the long-term goal in this project is to generate real-world evidence and actionable strategy to reduce disparities and also promote healthy longevity among these older people with HIV. So this project uses a multi-source data ecosystem. So clinical EHR data includes diagnosis and procedures and vitals, laboratory research, and medication from one Florida data set. So this one Florida data set includes longitudinal EHR data, and it's one of the largest real-world EHR data set in the United States. So this also project also links to like a Medicare and Medicaid. It's a claims data. So this also we use the claims data too, and clinical also like a clinical note or clinical narratives are processed with natural language processing to capture some like concepts that are not reliably available in structured EHR data set. So probably including like dementia-related information or behavior factors and social determinant of health concept and selected clinical characteristics. And also we add the contextual social determinant health data, which is linked like a geographically linked study. So we can study like how neighborhood, social, and built environment contribute to dementia risk and disparities. So that's kind of the one of the difference. And we believe this these kind of things allowed the project to investigate like both prediction accuracy and also health equity. So I prepared like a slide for my three specific aims, but I will not talk like more detailed, but I will just like briefly introduce the aim, each aim. So aim one here is about building a research grade like HIV and dementia cohort. So we prepared this cohort data first, and then aim two, developed machine learning based risk prediction models. And then we examined like the disparities in the dementia outcomes in this population. And also the aim three. So aim three actually translate prediction model, this risk prediction into an early warning system. So the early warning system kind of is a clinical decision support tool. So for example, if we have the prediction model here, it's fancy and it's really work great. But without using this clinical decision support tool, like a clinician or providers in practice, they cannot see this our prediction output. So using this clinical decision support tool, when the provider see the patient, actually they can see this early warning system on their EHR system. So for example, if the patient is at higher risk of dementia, then the provider can see here the sign as a, for example, something like a pop-up or alert or some like sounding. So that's, we call this like an early warning system, so that actually they can use in real world practice when they see the patient, and they can start some other intervention or some treatment or counseling, so some actual action there. Okay, so I prepared it here. And if you have a question, then really I'd be happy to discuss any of your agenda or answer any question if you contact me by email address, and I added my email address there.
Great, thank you, Hwayoung Cho. It's a really interesting presentation. That looks like a big project that's going to keep you very busy. Great. I was just wondering, how did you become interested in AI and start doing AI research as a nurse?
So the so my actually my interest did not begin with like AI itself. So my interest more likely began with like a clinical observation. So I work as a nurse like for 10 years. So as a nurse, like caring for patients with chronic conditions, I saw like a persistent gaps in support that extended beyond the hospital or clinic. So once they are discharged from the hospital or after their clinical encounter, then just like there are still a lot of things that we can contribute to their real world life. So my interest began with that area first, and that led me to nursing informatics and technology-based interventions. So I worked on mobile health intervention for HIV symptom self-management and medication adherence and physical activities. So the mobile intervention were connected with electronic pill bottle or the physical activity watch, so that they can actually use all together. So then after that, my work expanded to EHR usability and clinical decision support system. So over time, I became like a increasingly like interested in how this large scale real world data could support earlier risk of detection. So for me, AI and machine learning became kind of the way to bridge like a clinical care and patient everyday life, and also our as a nurse like earlier support.
Great. Yeah, sounds like a very interesting journey. Do you have any advice for nurses who might want to do something similar? How could they get involved and learn a bit about AI?
Uh, Probably my advice for nurses entering AI research is probably to start with a clinical problem, not just like with the technology. So AI is a tool, not a research question, right? So begin by asking what problem matters to patients and clinicians so that we can start from there and then define the population, outcome, and clinical settings and intended use. So after that, we can match the method to the question. So some questions may need like a prediction modeling, or some questions may need like a natural language processing, or just use of the generative AI, or user-centered design approach, or rigorous usability testing, or something other study design for the implementation science. So rather than just we say like, oh, I want to do AI research. If we have a clear clinical research question, then probably there are so many people like me who can help. Okay, then which method would be the best for to answer the research question?
Thank you. That's really good advice instead of jumping into AI first when sometimes it's not necessary or needed or it won't add a huge amount of value. We don't need to use it everywhere. My last question is a bit more difficult, but where do you think AI might go in the future and what kind of trends should nurses keep an eye on?
So I think nurses will see like a more rapid growth. We already have seen the rapid growth, but probably we will see still continually seeing like a rapid growth in AI enabled like clinical decision support and risk, especially like a risk prediction embedded in EHR system, our clinical workflow. So the generative AI will also contribute to continue to grow in like our nursing documentation or patient education, also training and clinical communication. So everything is like still evolving. So just like rather than focusing on just developing the AI prediction model, probably we can also think about how we can translate this prediction model into our nursing workflows. And also, I think multimodal models are another major trend. So just like these models combine like a EHR, electronic health record data, and also clinical notes. And also, we already have a lot of imaging data, so we can combine this. And also, as we already have increased like a mobile devices in use, so we also have wearable like sensors already, and also social determinant of health. So like life cycle monitoring can also become like increasingly important, like something like a calibration or model drift, fairness, safety, something like this. And also I see very strong role for nursing-led AI. So nurses are well positioned to lead in workflow integration and patient experience and implementation science and actually patient safety too. So I believe the tackle method here that the high quality AI in nursing starts with evidence, as I showed you today, and become useful through design and create like a value when it improves actual care. So that's my point for today.
Thank you. That's great, and all really important points for nurses and and AI going into the future. Well, thank you so much for your time. It would be great to check back in another sort of 12, 18 months and see how your dementia project progressed and finished up, and the results sound really interesting. So thank you so much, and best of luck with your research.
Thank you very much.